So it's my pleasure to introduce Dr. Mai. Dr. Lauren Mai earned her medical degree at McMaster University and completed her neurology residency at the University of Western Ontario. Subsequently, she completed a one-year fellowship specializing in stroke cerebrovascular neurology at the Population Health Research Institute of McMaster University. Dr. Mai joined the Department of Clinical Neurological Sciences as an assistant professor specializing in stroke in 2019. She is actively involved in international multi-center clinical trials aiming at stroke prevention and management. She is a collaborator with the Canadian Consortium on Neurodegeneration in Aging and a member of the Canadian Hemorrhagic Stroke Trials Initiative Network. Her local research looks at the differences in recovery trajectories between intracerebral hemorrhage and ischemic stroke survivors, and the use of rehab triaging tools in these two groups. Dr. Mai is passionate about teaching the next generation of clinicians and organizes teaching sessions for stroke fellows and residents. She is a faculty contributor to stroke courses provided by the Canadian Stroke Consortium. And with that, I'll turn it over to Dr. Mai.
Okay, well, thank you very much, Tina, for the kind introduction and the invitation to speak. And it's so exciting for me to see so much interest in this topic of intracerebral hemorrhage recovery trajectories, because it's something that's captivated my interest for this early part of my career. So I'm going to share my screen and we'll get right into it. So there we go. It should be showing up now. All right, so we're going to be talking about the pathophysiology of ICH, in particular recovery trajectories. To start, some disclosures. I do not have any relationships with for-profit organizations to disclose. I have, however, received grant funding from the Academic Medical Organization of Southwestern Ontario in the past to conduct research on this topic. Nothing of that should influence what I'm saying to you today. So Tina shared with me who we're expecting in the audience today, and it's an exciting mix of physiotherapists, occupational therapists, SLPs, RNs, and a lot of people that are highly involved within the stroke team. And so very happy to engage all of you professionals in today's talk. And at the end, I'll be looking for your feedback based on what your experience has been on this topic. Let me tell you about the case that first got me interested in this topic. It was when I was a stroke fellow. I was working at Hamilton General, and we had a 72-year-old woman who was admitted to the stroke unit. She was known for having experienced an ischemic stroke that was the left occipital region. So we can see that in the top image where she has the area of encephalomalacia. The etiology was atrial fibrillation, so she was treated appropriately with apixaban 5 milligrams twice a day. And she had made very good recovery and returned to independent living at home with a modified Rankin scale of 1, so indicating an excellent outcome. When she was admitted and when I got to know her was in 2018, when she experienced a left frontal parietal intracerebral hemorrhage. This intracerebral hemorrhage, strategically located, left her with global aphasia and right hemiplegia. So at the time of presentation, we would have graded her as a modified Rankin scale of 5, one of the worst outcomes for dependency. And as per the usual rehabilitation assessments, she wasn't found to make any meaningful gains. So the plan had been from the care team that we would need to get her to long-term care to accommodate her heavy care needs. But then something unexpected happened. It was an unexpected recovery. While she was awaiting discharge to the nursing home, bedside nurses were noticing improvements in her function. Hey, did she just help move her leg and help with that transfer? Does she seem to understand us now? So she was admitted for a rehab trial. And in fact, she made significant gains with her speech, with her swallowing, and her lower extremity control. And those gains were sufficient to be able to return home with family support. And I guess this is the case that got me thinking about how her recovery trajectory is so much different than what we can see in an ischemic stroke patient. I got asking the questions, is there a delayed recovery in intracerebral hemorrhage? And if so, why? And how does the recovery trajectory in an ICH patient compare to that with ischemic stroke? What does it mean for the long-term functional outcomes for survivors of ICH? And in particular for this patient, what would have happened if she had been moved to long-term care as had been originally planned before being reassessed for rehab? So then if we understand the recovery patterns in ICH, how does this affect our stroke systems of care? And so those are the questions I hope to address with today's talk. So my objectives for today's talk will be to examine with you population-based studies that have tracked functional recovery and to compare some rehabilitation outcomes by stroke subtype. And I differentiate here ischemic versus hemorrhagic stroke. We'll review some recent RCTs that might provide some additional insights on the long-term functional recovery in ICH. And I will introduce some results from the ALPHA-FIM study, some of my own research work looking at triage to rehab between ICH and ischemic stroke, and also a systematic review that I've done with colleagues to answer questions about long-term prognosis. In the end, there's 3 key words that I want you to remember when it comes to ICH recovery trajectories. That ICH recovery trajectories can be delayed, steep, but also protracted. And then I'll talk about what does that mean in terms of clinical and also research implications for these patients. One thing we should recognize is that ICH, we know unfortunately has a very high mortality, and it is the highest mortality subsite of stroke. The 30-day mortality from ICH ranges between 35 to 52%. And 50% of these deaths occur in the first 2 days. 1-year survival is about 46%, 5-year survival 29%. This is a group that also has a lot of comorbidities, and recurrent events can often lead to demise. What about the long-term functional prognosis after ICH? Does everyone do badly? So from a systematic review and a pooled analysis of 4 population-based studies, functional independence, that is a modified Rankin score of 0 to 2, and that means ambulating independently and able to live independently, was achieved in 32 to 42% of all ICH. Now, if we flip that and look just at the survivors, considering the high early mortality, 53 to 83% of survivors of ICH are functionally independent at 6 months. And so the way I interpret this is that if you do survive ICH, your chances of functional independence aren't that grim. So even though it's a disease with high early mortality, long-term outcomes aren't as bad. We have a lot of prediction scores in medicine, and the ICH score is one of those that was introduced as meant to be a simple, reliable grading scale for intracerebral hemorrhage. It was created to be a standard clinical grading scale for ICH, analogous to what we might use in traumatic brain injury or subarachnoid hemorrhage or ischemic stroke, as a communication tool between providers. And what it's based on is factors found to be independent predictors of 30-day mortality. And so that ends up being the Glasgow Coma Scale, your age, and it dichotomized between more than or equal to 80 years old or less, dichotomized volume as less than or greater than 30 mils, the presence or absence of intraventricular hemorrhage, and infratentorial origin of the hemorrhage, with infratentorial hemorrhages being more dangerous and associated with higher mortality. And the original authors who published this score were showing that in those who had ICH score of 1 or 2, there's very high likelihood of survival, but those who had ICH score of 4 or 5 have a very high risk of 30-day mortality. Now, in publishing this score, the authors very rightly put out this warning. They said, while prognostication is undoubtedly important to assess treatment benefits and risks and to provide patients and families with information regarding severity of illness, attempts to precisely prognosticate outcome may lead to inappropriate self-fulfilling prophecies. And I think that that brings me to the big warning about trying to estimate upfront long-term prognosis after ICH. And that's exactly what was seen after this score was published, is that self-fulfilling prophecies probably started to be taken into account. What was the limitation of this study is the absolute numbers that they had in some of those groups. So they had numbers less than 50 in some of those ICH scores of 3 or 4. Now, and those ones are the 4 and 5s were associated with very high mortality. ICH scores of greater than or equal to 4 have led some physicians to advocate for a de-escalation or withdrawal of care based on perceived futility of further therapy. So as an example, there was one study that showed that there was lower rates of EVD placement in ICH grade 4 versus 3, 20% versus 47.6%, despite higher rates of intraventricular extension. So intraventricular extension would usually be the indication for EVD, and also that ICH scored had reduced predictive ability when withdrawal of care is excluded. So if we didn't include DNR orders, then we see less predictability of the ICH score. A do not resuscitate order in an ICH patient is associated with a nearly 2.5-fold increase in patient mortality compared to ICH score matched non-DNR patients. And of course, we understand that DNR orders can often be a proxy for comorbidities or a marker of treatment aggressiveness, so it's hard to interpret. I'll pause here because I think Tina might have a question.
Thank you, Dr. Mai. Melanie has raised her hand, and if you'd like to ask your question, I will unmute you. Oh, I don't know, Melanie, are you able to, did you have a question? Okay, maybe we'll continue. So that might be have been a hand up in error.
Sure,
Thanks.
and happy to come back to it if the question comes up again, okay? All right, so one of the reasons why it is so difficult to prognosticate early on in ICH is because of this reason of the perihematoma. So if we consider 2 patients presenting with stroke, one with ischemic stroke and one with hemorrhagic strokes that are presenting perhaps with equal severity of stroke on a neurological scale. The patient with ischemic stroke has a certain defined area where there's been ischemia, lack of blood flow. So I've given you an example of an MCA superior division infarct there on the right. On the left, we see a patient with similar location and similarly sized area of lesion from an intracerebral hemorrhage, giving similar deficits. But the difference is, in an intracerebral hemorrhage, the total lesion volume accounts for both hematoma, which would be areas of the immediate mechanical destruction and neuronal death, but also that of the perihematoma edema. And the perihematoma edema represents an area of potentially recovery. And so it may not always be irreversible injury like we see in ischemic stroke. We also know that the changes within the hematoma and the perihematoma edema can also be delaying the onset of recovery. So a patient will often look worse off than they may be in the end. And so let's look a little bit more about why that delayed recovery. So we know, of course, that the intracerebral hemorrhage epicenter is an area of primary injury. That's the mechanical destruction by the hematoma. But surrounding that, there is ionic edema that will develop over hours. Over days, we have the effects of vasogenic edema from plasma proteins and the destruction and the breakdown of blood products. We also have inflammatory cascade, usually incited by the thrombin within the clot, developing over days. And over days to weeks, which is also accounting for this delay in recovery, we have the effect of hemoglobin degradation and iron neurotoxicity to surrounding areas. This is a study that looked at the temporal profile of perihematoma edema growth after spontaneous intracerebral hemorrhage. And so, unlike our patients with ischemic stroke, who will be most severe and maximal neurological deficits usually at onset. In intracerebral hemorrhage, we may see that, in fact, worsening happens in the days that precede the onset in ictus. So, and why is that happening? It's because it probably is taking 8 to 14 days, 1 to 2 weeks, for this perihematoma to reach its peak size. And then we don't see that involution until beyond the first 2 weeks of presentation. And so it would, from a pathophysiological basis, we shouldn't expect our patients to start to show their recovery or give us a sense of their long-term prognosis at the onset. There's also a role of inflammation. So in the perihematomal region, particularly regional microglia, will transition from a pro-inflammatory to an anti-inflammatory state within the first 2 weeks after ICH. And if we can understand microglia as the predominant immune population in the CNS, we know that when they are on to an anti-inflammatory milieu, that's associated with wound healing and repair, and what we see clinically as recovery. And so this was an interesting study that showed that in those who ended up displaying more of the mediator reparative phenotype in microglia, they showed improved recovery in ICH. Now, this should be taken with a grain of salt because it's a very small population, but it's showing that there's lots of things sort of beneath the surface that are happening pathophysiologically to account for delayed recovery trajectory. Does this bear out into population studies? So let's look at the South London Stroke Registry. This was a large population study defined in a defined geographical area, so of South London, and they captured people from January 1995 to December 2011, and they would have had 3,730 people with a first onset stroke during that time, about 15% of which would be ICH. And what they did was they tracked their improvement week to week over the first year, and they looked at mean improvement in the Barthel index. What they could see is that that mean improvement in the Barthel index from 7 days to 3 months was much higher in ICH when you compared it to ischemic stroke. And we can see that in the graph. The dashed line underneath is intracerebral hemorrhage. The solid line is ischemic stroke. We can see that our ICH population, almost as expected, starts off more severely affected. This is their graphing proportion with a good outcome. So there's fewer of them that have a good outcome at that time. But with time, it's like the ICH population catches up to ischemic stroke. And then we also see that relatively kind of stable throughout a long-term course. They saw a significant difference by stroke subtype remained after multivariable linear regression adjustment for casemates for the often factors that we know would affect, like age, gender, and baseline comorbidities. So this is a sub-study of patient-specific recovery where they captured the Barthel index at multiple week points to look at recovery with time over the first year. And patients with ischemic stroke had significantly improved recovery in the first week, which goes back to what I was telling you about pathophysiology in ICH. Compared with hemorrhagic strokes, but thereafter the tables flip, and it's hemorrhagic stroke that has the much steeper recovery thereafter, gaining more Barthel index points after the first week compared to their ischemic stroke counterparts. So knowing what I've told you from pathophysiology and the population studies, we can expect delays in recovery in ICH, but that there's a lot of potential for gains after that initial delay and for steep gains. Let's look at some of our current stroke systems of care. So in a patient in Ontario Stroke Quality Best Procedures Clinical Handbook, target lengths of stay for stroke patients, they give 5 days for ischemic stroke and 7 days for ICH. The Ontario Stroke Network recommends a day 3 alpha FIM or other measures to help assess rehab candidacy. And in many ways, when we have these target lengths of stay and we have a recommendation of when to assess for rehab candidacy, we know that there's a bit of a pressure on deciding where this patient is heading and helping to understand discharge disposition. Is this person too good? They're ready to go for home once medical issues are cleared up. Are they sort of in between. They're at our rehab ready stage, and we're thinking about applying for inpatient rehab or other rehab streams. Or in many cases, there can be blood pressures to make a person plan for a long-term care destination or ALC for other discharge disposition. So I wanted to look at this and understand really, what's the utility of the alpha FIM, and particularly at day 3 in intracerebral hemorrhage survivors. And so I had looked at, as a few research objectives with this project, comparing the predictive value of our current functional assessment tools between patients with ICH and ischemic stroke. I looked at determining the optimal timing of selecting rehab candidates by stroke subtype, and I'd like to investigate patterns of recovery in ICH. What is the alpha FIM? I know that most of you in the audience will be very familiar with this. And it's just to remind you of 4 motor items and 2 motor items. It's a subset of the functional independence measure. And so depending on whether a person is mobile or not independently mobile, will affect what the motor items are. And the non-motor items are expression and memory. So it's something that takes our OT, PT, and SLPs a team effort to come up with this alpha FIM measure. Why do we use the alpha FIM? Well, it's a reliable, established validity in stroke patients, and it's endorsed by the Canadian Stroke Best Practices, the Ontario Stroke Network. However, the alpha FIM, I should note, has not been validated in a population of patients with ICH alone, nor has its reliability and validity been compared between hemorrhagic and ischemic stroke patients, and that's why I wanted to test this. Might the alpha FIM help explain some of the differences in stroke recovery trajectories between these 2 subgroups? So in the study that I did, I looked at consecutive stroke survivors admitted to Hamilton's Regional Inpatient Stroke Rehab Program over a 5-year period. So we polled from 2011 to 2016, and those who would have had admission and discharge FIM scores. And there were 1,370 patients treated during this time. 51 were excluded for diagnoses other than stroke, but that they had still made it to the stroke unit. And then 87% of the population was ischemic stroke, about 10% was spontaneous ICH. And most of these would have had completed alpha FIM, so we could look at it. So here's the baseline characteristics of the cohort examined. We can see that the ICH patient population is younger than ischemic stroke, about equal numbers of women in each ischemic and ICH group. And if we look at the alpha FIM, we can see that those admitted to rehab during this 5-year time period had slightly lower alpha FIM mean scores in the ICH group compared to ischemic stroke. But an important finding here is the time to triage and the date of that alpha FIM that allowed them admission to rehab was done in a delayed fashion compared to ischemic stroke at 11 days for ICH in comparison to ischemic stroke of 7. And of course, the other thing to note is that that is delayed beyond the day 3 recommendations as it is. The length of care and length of stay in acute care was also longer in ICH than the ischemic stroke population. When we look at rehabilitation outcomes by stroke subtype, we were able to capture admission and discharge FIM in both groups. And from there, we can calculate FIM change, and FIM efficiency being the FIM change divided by the active length of stay. We did not see differences in the ICH versus ischemic stroke population, although there are trends that the ICH group had a FIM change of 26 versus ischemic stroke of 20. And length of stay was slightly longer in the ICH group compared to the ischemic stroke group. So I think the point here was that although there were differences in the baseline severity of the ICH population, their rehab outcome measures, the FIM gain and FIM efficiency, were not statistically different. And interesting that we saw that even though those who with ICH were more functionally disabled at the time of the alpha FIM assessment, and it took them longer to get there. So if we look at the predictive value of the alpha FIM by stroke subtype on rehab outcomes, this was done just by simple linear regression analysis. And we would expect that the alpha FIM designed to predict the full FIM would closely approximate the admission FIM scores. What we see is that FIM change is inversely correlated with alpha FIM. So what does that mean? It means that you have a lower FIM, alpha FIM at admission, meaning you're worse off, you have more to potentially gain from rehab. And so the alpha FIM, which is interesting, although statistically significant in its p-value, does not account for a large proportion of the variance in outcome measures of FIM gain or FIM efficiency. So I think we have lots more questions to ask. I looked at the FIM efficiency by alpha FIM categorization because we often say that those who are rehab ready are usually like well-defined rehab ready in the alpha FIM 60 to 80. Those who might be too good are usually over 80. Sometimes those are headed for outpatient-based therapies instead. And then less than 40 is often seen as maybe too difficult, too disabled to benefit from rehab. And then I wanted to look at all these different categories. And what we saw is between, so the dark green line is FIM efficiency in intracerebral hemorrhage, and FIM efficiency in ischemic stroke is the lighter green. There were similar FIM efficiencies in all categories, with the exception of the more severely disabled group of ICH patients and versus ischemic stroke, where the FIM efficiency was statistically better in that category. So it's something hypothesis generating, definitely, to think that maybe those with ICH that are more severely disabled are having better benefits. So what were some of the conclusions? Well, that we could say that the alpha FIM appeared to be just as reliable in predicting main rehab outcomes, regardless of stroke subtype. Compared to ischemic stroke patients, ICH patients admitted to inpatient rehab were younger and had more functional impairments like lower alpha FIM scores. They had longer times to triage. Remember the 11 days versus 7 days. And so one of the thoughts is that a day 3 alpha FIM is unlikely to capture which ICH patients are rehab ready. And compared with their ischemic stroke counterparts, there is significantly higher FIM efficiency in ICH patients with moderately severe deficits. The limitations is that this is bias, of course, from inclusion of an inpatient rehab population. So there's something that biases who gets into inpatient rehab to begin with. We have the limitation of it being a single site. It's a small sample of ICH patients with a retrospective nature. So let's see what other rehab studies have shown us with the difference between ICH recovery in inpatient rehab compared with those with ischemic stroke. This is the CATRAC study from 2009. It was a retrospective study of consecutive stroke admissions over a 4-year period. They were able to capture over 1,000, with 193 being ICH. In the ICH versus ischemic stroke cohorts, they had lower admission FIM scores, but a greater FIM gain, so 28 points versus 23, and that was statistically significant in this study. And their conclusions was that ICH patients with the most severely disabling strokes had significantly greater recovery than cerebral infarction patients with stroke of similar severity. Is this a sustained thing? Did other people see this? So this is the Kelly study, and they had consecutive stroke admissions, 129 ICH patients compared to 589 ischemic stroke, so slightly smaller. But the ICH group did achieve a greater FIM efficiency. They achieved a greater motor assessment scale, and the stroke type remained a significant factor for FIM gain, even when adjusting for admission FIM, which we know can be inversely correlated, for length of stay, for age, and days from stroke onset to rehab admission. So that was interesting to suggest the ICH patients do show very good rehab outcomes. Here's a study from London, Ontario by Dr. Teasel and his group, and they compared hemorrhagic stroke to ischemic stroke, again, their inpatient outcomes. The patients were similar in age, maybe a little, they were definitely, so to other studies, but younger in the hemorrhagic stroke population versus ischemic stroke. And let me highlight for you that what they saw, they did not see differences in the FIM on admission or the FIM on discharge or the FIM efficiency. So they were saying, hey, this ICH group is doing just as well as ischemic stroke. It goes to show probably who they're taking was similar in population, one to the other. But one interesting thing is that the number that came in a wheelchair with hemorrhagic stroke compared to ischemic stroke was greater. But by the time that they left, those numbers really reduced, and it wasn't different. So there were more people that were probably learning to walk in the hemorrhagic stroke population. One of the limitations of this type of retrospective review, where you take all comers and the consecutive admissions, is that there's something that it affects admission criteria. And so one way to get around this is to do a case control study where patients with ICH with first-time intracerebral hemorrhage, first-time stroke were compared to an equal number of those with first-time ischemic stroke. And they match them for the things that we know have an impact on rehabilitation outcomes. So they matched for stroke severity, basal disability, age, sex, and onset to admission interval. Patients with ICH show 2.5 times greater probability of high therapeutic response on the Barthel Index, which is a nice measure of functional outcomes, than the ischemic cohort. And if they looked at the CNS score, which is a marker of neurological recovery, they looked at Barthel Index, and they also looked at the Rivermead Mobility Index, so a marker of mobility. Their rehab effectiveness in the ICH group, on that bar graph, it's the dark lines, was better than the hashed ischemic stroke on all of those measures, which is quite encouraging. So should we attempt early rehab in ICH is another clinical question that's been examined. Does early rehab within 48 hours of stroke improve survival and functional outcome in patients with ICH? That was the objective of this study. This was done in China. It was a multi-centered RCT with blinded outcome assessments at 3 and 6 months. They collected 243 patients to participate. And design of the trial, similar in many ways to the early rehab trials that had been done around this time. Interestingly, what they found was that those in the standard care group were more likely to have died compared to the intervention, which was very early rehab plus standard medical care. They had an 11 versus 3% mortality, so that is statistically significant. They did not find significant differences in short-term improvements in secondary outcome measures at that 3-month point. But from the 3 to 6 month period after stroke, there was a statistically significant difference between groups for all outcomes in favor of the intervention group that is receiving very early rehab. So they saw improvements with the physical component, the mental component, the Barthel Index, and the anxiety scores as a quality of life measure as well. Importantly, the Barthel Index, we think of that as a nice correlate of functional outcomes. There was a 13-point difference between the groups to show the benefit of the intervention, and that makes clinically important difference for Barthel Index. So I guess one thing that we learned from this and a potential hypothesis is that interesting that they didn't see the difference when they first did the outcome assessments at 3 months, but they saw it at 6 months. So is there a delay in the plateau of recovery? So let's look at some population studies that have looked at a longer duration, and they've compared here ischemic stroke versus hemorrhagic stroke. So ischemic stroke is the hash line and the solid line is the ICH group. In China, they have higher percentages of their strokes being ICH. So about a quarter of their strokes are ICH. So we have over 6,000 patients, but a good 1,572 of them are ICH. And here we see a significant difference was observed between the stroke subtypes when they compare the slope of recovery. So this China Quest study tells us, yes, there is a significant difference in the slope of recovery. And if I were to just extrapolate a little bit, I'd ask the question, well, when is it that patients are showing a recovery plateau between the groups? The blue line, it would be where I visually inspect and say, yeah, there looks like there's a plateau for the ischemic stroke group, and that happens at about 30 weeks, so about 6 months. But the plateau in the ICH group, which not surprisingly, they start off with poor outcomes, and they have poor outcomes throughout the duration of the observation period, but their plateau is happening in a delayed fashion. And if we estimate that, it looks like it's happening just past the 50-week mark, so like at a year mark. Does this bear out in another population? So let's look at another population. Here's the Streetus stroke register. Again, what they're plotting is percentage. They're plotting MRS. So the white part of the graph is those with independent outcome, and then we have MRS 3 is the light gray. MRS 4 and 5 are the darker and then full black. And this is long-term functional outcome after stroke in looking at just a group that starts off as pre-stroke independent, meaning let's get rid of whatever ceiling effect from pre-existing comorbidity. This is a large population that was studied, almost 23,000 patients, and here less of a percentage of ICH, but still a large number based on this large population study, 12.5%. We see less favorable outcomes overall in the ICH group versus ischemic stroke at all time points. And what they're charting on the bottom, you'll see before stroke independent. So this is the group that's all independent. And then we have 3 months, 12 months, 3 years, and 5 years, comparing ischemic stroke to hemorrhagic stroke on the right. And I would say, again, if I, and visually inspect, I'm seeing a bit of a suggestion where there's a plateau early on in ischemic stroke, but that doesn't happen until a little bit later with the ICH group. So here's me adding in my estimate of where I see a plateau. We don't have that intervening time frame, a measure between 3 months to 12 months, but it looks like in the ischemic stroke, the amount of people who are going to make a recovery to independence seems to have reached its peak by 3 months. Whereas in ICH group, there definitely seems to be more people who have reached into that group of ischemic to independent outcome from 3 months to 12 months. Some of these population studies have looked at predictors of that functional outcome in ICH. So what are some of these predictors? So I would point you towards scores like FUNCT-ICH or the ICHOP score, and they contain common variables of ICH volume, age, location. So lobar bleeds have better chances of improvement than deep or than infratentorial, where you might have involvement of the brainstem, for example. The GCS score at onset is important. And of course, pre-ICH cognitive impairment as well will influence whether you get to independence or not. The China Quest study found that there were different predictors between ICH and ischemic stroke. In ICH, they saw low education atrial fibrillation being associated with poor outcome. They found that antihypertensive use was associated with improved outcome. The South London Stroke Register had found that age and incontinence were associated with poor outcome. In the German registry, they had looked specifically to say sex did not seem to have a difference in long-term functional outcomes. And those who had experienced the complication of systemic inflammatory response syndrome, that was predictive of poor long-term functional outcome. A recent study was published in last year in stroke that looked at location-specific hematoma volume cutoffs and clinical outcomes in intracerebral hemorrhage. So that this nice graphical representation shows you, based on location of the bleed, the amount of volume that still seems to be associated with good outcome, with poor outcome, or with mortality at 6 months. And we can see that that volume is very highly dependent on the location. So of course, you can only withstand a small volume of intracerebral hemorrhage in the brainstem or in the basal ganglia, whereas in lobar hemorrhages, even lobar volumes of less than 40.5 mils are associated with good outcome versus in the, let's say, the internal capsule, less than 5.5 mils, or the brainstem, less than 3 mils. So we had looked at a couple of different population studies that looked at this long-term functional recovery in ICH, but I wanted to add some quantitative value to that, what I was observing as a trend in looking at these population studies. So with a bright medical student, Randy Mao, we did a systematic review, searching articles where we put an inclusion criteria anywhere from 1970 to up to when we did the study, which was 2020. They had to have a population of reporting at least 50 spontaneous non-traumatic ICH. They were an adult group, and they had to report any measure of functional outcome for at least 2 defined time points for the acute phase of recovery. And so what we were able to identify, we did a very thorough database search. 5,789 records were screened. We assessed 108 full text articles, and then we ended up with 19 studies included in the qualitative analysis and 17 studies that we could do a quantitative synthesis and meta-analysis with. Because we had these varying broad inclusion criteria, not all the studies were reporting the same outcome time points. So of 19 studies, there were several that were able to report both 3 and 12-month post-stroke outcomes. And we looked at what was defined as good outcomes. So for some group studies, it was the Barthel index. For many studies, it was the modified Rankin scale. And we said, what we're seeing visually, the question was, do patients continue to improve from 3 months to 12 months in this sort of meta-analysis? And yes, in fact, they do. So it was more statistically likely to see a good outcome, higher proportion of good outcomes at 12 months than at 3 months. The risk difference is there. And what that translates to is the number needed to follow 41 to see one additional favorable outcome at 12 months compared to 3 months. We had questions about other time points as well to try to give us a sense of plateau. So we looked at 3 months, at 6 months. 6 studies allowed for comparison of outcomes from 3 to 6 months post-stroke. So achieving a modified Rankin scale of 0 to 2, an independent outcome at 6 months relative to 3 months had a significant risk difference. And that was very highly statistically significant. So conclusion, yes, there are improvements that happen from 3 months to 6 months in ICH. There were 6 studies that allowed comparison of outcomes from 6 to 12 months post-stroke. And interestingly, there were no appreciable change in good outcomes from 6 to 12 months in the studies that reported these outcomes, either if we defined it as good outcome from 6 studies, or if we specifically stated MRS 0 to 2 from the 5 studies. One thing to note, there's a lot of heterogeneity in the outcomes that were reported. And of course, that was part of the limitations are very, very broad inclusion criteria. But the hypothesis that we generated from this is that most long-term changes are probably gained by 6 months. So randomized controlled trials, when they are designed, need to think about when are they going to ascertain their outcomes. And this is done, of course, a little bit based on what is the usual thing to do with ischemic stroke trial design. And so we're borrowing from the ischemic stroke literature trials, where conventionally we would measure 90-day outcomes. But also, we have to take into account these differences in ICH and how we think the treatments that are being provided might be helping. So this is the IDEF trial. The IDEF trial was designed to look at an iron chelator named deferoxamine. Now, the primary trial that was reported, unfortunately, was futile when they had used their primary outcome as a 90-day modified Rankin scale of good of 0 to 2. But they had pre-specified a 180-day outcome. And if they had instead used that 180-day outcome, so the 6-month time mark, this would have been a study that was non-futile and would have gone on to bigger studies. And what's interesting is when they look at the percentage of patients with an MRS score 0 to 2, so independent at different time points, we can see that both the placebo and the deferoxamine group continually increased their proportion of patients who achieved that good outcome from day 7 to day 180, but where the differences were most marked was in the deferoxamine group from day 90 to 180 compared to the placebo group. So that's where we might have potentially seen this treatment take off. And so, of course, has a major influence on our design for RCTs and what ends up happening as the outcome of these trials. I've shown you a bunch of population-based studies where we look at the proportion of patients achieving good outcome in aggregate. Here's a nice study. It was trying to look at the ICH score and its predictive abilities, but now tracking what's been graphed is individual movements, and the weight of the arrows tells you about individual movements of ICH patients from different MRS categories. So in part A of the graph, the gray arrows represent the proportion of the people being tracked with ICH survivors that stay at a certain category. And the other arrows, based on their weight, show you the movement between categories. We can see that in that part A of the graph, there's a lot of movement upwards from day 30 to 3 month point, but that doesn't stop. It continues from 3 months to 6 months. And there's even some movement, but not quite as much as the early movement from 6 months to 12 months of people moving along that trajectory of functional improvement. Part B of the graph shows also downward arrows, and those downward arrows are usually people who have developed unrelated outcomes that have halted their recovery or, led to an MRS of 6, which is death. So this is kind of, I should explain in a nice graphical form, some of the limitations of looking at this all in aggregate when you look at proportion, that we might see a proportion of people that achieve a modified Rankin score, whatever 0 to 2 increased by a certain amount from this time point to that point, but it doesn't tell you that there's also people that are also losing, like on their modified Rankin scale because of some of these comorbidities. We're nearing the end, okay? So this is data from RCTs that were looked at again, the CLEAR 3 and the MISTY 3 cohorts. So these are 2 surgical trials that were done in patients with ICH. As you can see that what this graph is showing you is that the distribution of modified Rankin scales from day 30 and then to day 365, and their 1-year outcomes were their primary outcome. This is a group where, because these people were wanting to participate in this surgical trial, it was not a group with do not resuscitate orders. It was kind of aggressively medically treated. You can see that this is a group that, for the most part, starts off with more severe disability, because most of these people are in an MRS category of 4, which is the bright red line, and an MRS 5, so most dependent, at the 30-day mark. But surprisingly, the second part of the bar graph shows you that there's a lot of movement. And even those with an MRS of 5, some of them can still achieve the better outcomes, so MRS 0 to 3. And there's quite a bit of movement there in the MRS 3, 4, and 5 group. So what happens to these ICH survivors with poor outcome that are sort of more aggressively medically treated? We can see part A is showing you the distribution of MRS scores, and with those who started off with poor outcomes in the 4 or 5 group in the CLEAR 3 trial, and B is the MISTY 3 trial. So we can see that at day 180, we don't still have everyone still stuck at MRS 4 or 5. Instead, we've started to see good outcomes show up. And there's still some movement and increase in modified Rankin scales from day 180 to 365, but that most of those dramatic changes happen somewhere between day 30 to day 180. Here's kind of combined data of that to give another sense. Those who achieves a modified Rankin scale of 0 to 3, so not excellent outcome, but able to at least ambulate independently, versus 4 to 6. And we can see that from day 30 to day 180, there are more people with good outcomes, less with poor outcomes, and that still increases slightly from day 180 to 365. So that brings us to my conclusions, and I hope I've shown you with this data that when we think about ICH recovery trajectories, think about delayed, steep, protracted. So delayed, think about the pathophysiology behind ICH, that there's both hematoma as well as perihematoma that accounts for the full lesion volume. Steep, we think about all those rehab studies that showed that increased effectiveness, the high FIM gains in an ICH population, and that those ICH patients with the most severe strokes as a group will often outperform the ischemic stroke cohort. And then protracted, that's from this more recent RCTs, as well as the population studies, where it just seems that that plateau is not happening at 3 months. It's not happening at 6 months. It's happening in a delayed fashion, and that we can continue to see those movements. What does this mean? I think that it means as stroke teams, we have to be considering when we assess patients for rehabilitation, that these patients often need to be reassessed to see if they're rehab ready, that they deserve chances at rehabilitation, and they may need ongoing support to maximize those outcomes throughout the long run. And I'll end, hopefully we can open it up a little bit. I know that within the audience, with the PT and the OTs, the SLPs, the nurses that have been involved as stroke navigators, we have a wealth of experience. So I'd be happy to hear some of your experiences about what you've seen with Recovery Trajectory. Happy to get your questions. Yeah, and I'll turn it over to Tina.
Thanks, Dr. Mai. We don't have any questions and in the chat or in the Q&A now, but you've posed some questions for reflection. So if anyone would like to raise their hand, this is also perhaps easier than writing. You may want to verbalize your question. And while that's happening, just again, in the chat, there is a link to feedback that we'd love to hear from you, as well as the links to register for some courses. So Dr. Mai, one of the questions that came to mind for me early on as you were talking about the high mortality, what sort of is the time frame where you would expect after which, yes, they're going to survive?
I think that whether they're going to survive is a question of, are we early survival or delayed? So unfortunately, when someone has intracerebral hemorrhage, if we think about the most common types of spontaneous intracerebral hemorrhage being either cerebral amyloid angiopathy causing many of our lobar bleeds, or if we think about a cerebral small vessel disease and deep penetrating arteriopathy as the cause of some of the basal ganglia, thalamic bleeds, the deep bleeds, this is a group that is not without comorbidities. And so there's both surviving the intracerebral hemorrhage, there's surviving complications of ICH, and then there's just sort of the substrate of those who have ICH. Often it is a high comorbidity population to begin with. So sometimes based on pre-existing comorbidities and pre-existing patient values and wishes, there will be times where maybe it is appropriate to have goals of care conversations up front because the patient's coming with pre-existing wishes based on comorbidities. In most cases, we would say delaying some of those discussions to the 24 to 48 hour mark at the minimum is a little bit more important as a prognosticator, because we can often, end up leading towards those self-fulfilling prophecies. But yeah, so I think probably within the first week is when you can have some of those conversations about what to expect and the trajectory. But sometimes in those first few hours, it's too early to tell.
Okay, thank you. Rhonda has a question, and so you can unmute, Rhonda.
Thanks, Tina. Thanks, Dr. Maya. Great presentation. So I know something that things our teams then struggle with is, we know with the AFib to be done by day 3, we're trying to then determine and know with that sort of 7-day length of stay for ICHs, which you flagged as being really challenging. But based on the fact that, day 14 is where we're sort of seeing that perihematoma size, we're not really seeing a lot of change. What would your recommendations for sort of when to reassess, when to think about this, especially with somebody with a pretty sizable ICH? Like, when should our teams be reassessing? What conversation should we be having with the families to support that?
Yeah, and I think this is a question that we have to answer in a way that it keeps patient centric, but on the other flip side of that, we're also thinking of, we come at it with that resource and allocation questions as well. And so if we were doing it purely on trying to give a patient the best ability, it would be multiple reassessments that they would get. And so we would maybe have that early assessment and know that probably we're coming back to do it again. And then based on what we're hearing from the medical team in terms of medical complications and medical stability, when there's a medical stability, we're reassessing, maybe redoing an alpha FIM. And perhaps that is at the 2-week mark, but for others, that might be at 3 weeks. And it could even be there's a reassessment at 2 weeks. And because we've seen that there's been improvement and we see that this patient is now able to participate, well, maybe there's a reassessment even later. I think the difficulty becomes when sometimes there's a very strong delay because of maybe there's been a need for surgical treatment. And so a patient has an EVD or they have complications, and that those, whatever is happening, they're being treated for pneumonia, plus they have an EVD. It just makes it so that it's harder to assess their rehabilitation readiness. And from a medical standpoint, they're not ready. It's let's not lose this patient though, when this is finally done. And I think that's the big challenge, is when it's protracted and they are maybe thinking about complex care. How do we find them again when they do become ready?
Thanks.
Okay, Eileen?
Thanks, Dr. Maya. I have lots of questions and lots of thoughts, so really appreciate your presentation and the data that you're able to present. So definitely seen as you presented where that opportunity for the person with a hemorrhagic event, that it can take anywhere from that 30 to 180 days for them to really demonstrate their recovery. But then to a certain degree, some might, even pass where some of the ischemic patients peak at, let's just say. So I definitely think, and we certainly know in our stroke world, there's been a lot of conversations around, is there 2 streams? Is there a stream of timelines for inpatient care that we look at for ischemic? And then we should be looking at something very differently for hemorrhagic, as Rhonda's questions just highlighted. My question for you as well is, seeing this data, we have this constant debate right now about rehab intensity and how it influences. Do you see any clear evidence for the ischemic patient, how that intensity of rehab can play a role, especially if we see a delayed recovery more at the 30 to 180? We certainly know through the Rehab Care Alliance, the whole, definition of intensive rehab versus high intensive. Do you see where rehab intensity can play a role here, or is that another piece yet to be unveiled?
Yeah, and I would say that there's still so many questions, and oftentimes I've been asking these questions and it just leads to more questions and not as many answers. But I would say, from what we understand from the recovery trajectory of ischemic stroke, it makes sometimes sense to focus resources intensively where there's going to be the maximum recovery, and so early on in the first couple of weeks. That's a different story with intracerebral hemorrhage. because of this delay that they may not be ready. And from, I tried to show that one example of the microglia, right? So the microglia aren't even in wound repair mode until 2 weeks, perhaps, right? And that there's a switch that happens later on. And with what's happening with ionic edema, like, I don't know if it's the right time for those neurons to be reconnecting and resynapsing. So, but at the same time, you wait and wait and wait. What's going to happen to that intracerebral hemorrhage patient is they're going to have more comorbidities. They're going to slip backwards and they're going to be deconditioned. They won't be primed to do the recovery when they're able to. So I think there's an argument for a slow stream to begin, and even opportunities where maybe in a delayed fashion with kind of a little bit of maintenance kind of work, there's going to be a time where we capture them starting to do that takeoff, and then we're able to re-offer kind of more intensive services. So having kind of entry points for an ICH population might be a potential solution to kind of balancing a patient-centric recovery needs with resource allocation, because it can be such individual differences in recovery. And so just as an example, I had a patient who had an intracerebral hemorrhage and multiple comorbidities involving seizures, an intensive care unit stay, and he was discharged to long-term care. Well, I'm seeing him in follow-up a whole 8 months after ICH. And now he's starting to be able to transfer, and he's showing a lot of potential for actually learning to walk independently, to the point where it would make sense for him to try to get back home if he had those rehab supports. So then I contacted our stroke navigator, because then he was reevaluated, and well, he wasn't a candidate at 2 weeks or 1 month or 3 months or 6 months, but now at 8 months he was. So then, are we able to provide those resources when the time comes?
So that's just argument for us as we're building our systems to not just necessarily based on in-hospital care, but other avenues, but for that intensive therapy, at the right time.
Yes.
Okay, well, thank you, Dr. Mai. It is just after 3, so I know people do need to get back. I want to thank you very much for this presentation, and give us a lot to think about. Rhonda does have her hand up, so I don't know if you have a few extra minutes that you can answer her question before we close the webinar.
I actually I forgot to lower my hand, so I'm fine. Thanks.
Okay, okay. All right, thank you. So thanks again, Dr. Mai. This was a lot of information for us to process and to think about as we're moving forward. Okay, thanks everyone. Have a great rest of the day.
Thank you very much.